Good morning. We're going to go ahead and get started. I'm David Lewis. I'm here to welcome you to the Levy Lectureship. This is truly a great honor to be here today. Your guest speaker, I was a young medical student, very naive, wandering the halls of this place many years ago, and Dr. Benzil was the only neurosurgeon here, and so you would see him all hours of night and day, kind of like you do neurosurgeons at a medical center today, unfortunately. But he had a great reputation and just a wonderful guy. I still remember him having music. He played music while he operated, I believe, back in those days. Still do. Yes, sir. So anyway, I want to welcome you. This is truly a great thing that the Levys have done, and welcome to the Health Science Center.
First of all, I'd like to thank Dr. Lewis for coming by to give the opening remarks, and I want to congratulate him on his recent appointment as Dean of the School of Medicine effective June the 1st. So in another week, he'll be Dean Lewis. So congratulate him on that. For other thanks, I want to thank everybody who's been able to attend here to the 15th Annual Levy Lecture, neurosurgeons and neurologists, orthopedists, residents, fellows, students, nurses, and our clinical employees, as well as other guests. We have to also have special thanks to our sponsors. I'll read these off: Depew Synthes, Medtronic, Integra, Codman Neuro, and Zimmer Biomed. Their financial support is very important to the ability for us to hold these conferences. Lastly, I want to give really special thanks to the generous endowment by the Levy family, who this lectureship is named after. And I'm going to have Michelle come up to make a few comments on behalf of the Levy family.
Hi, my name is Michelle Doolittle. I'm a physician assistant faculty in the Department of Neurosurgery. I'm also a Levy. There are only 5 remaining Levys in our family. It's important to us that we started this visiting professorship so many years ago. And it was actually started, for those of you that don't know, because Dr. Nanda was able to save the life of one of our family members who had a brain bleed. And so our family has we feel very strongly about charitable giving and doing a lot for the community, and that's why the visiting professorship was started. And through that, we've been able to have amazing speakers like Dr. Benzil join us every year. So thank you for being with us today. I think one of the most important things as clinicians is that you realize that by saving someone or making a difference in the life of a patient, you also affect their entire family and their entire little ecosystem of everyone that is important to them. And so that is something Dr. Nanda was able to do for this specific member of our Levy family, and that all of our clinicians are able to do regularly. I would also like to say congratulations to Dr. Menger and Dr. Story. I have loved working with both of you, and I know that the future holds amazing things for you both. And although I won't see you after a couple of weeks as I move on as well, congratulations to you both, and I know the future holds amazing things for you. And I hope you enjoy the speaker today, and we are just so honored that we still have the professorship available so that the professors are able to come and that we're able to learn from them. So thank you all for being here today.
It is both a great honor as well as a great pleasure for me to introduce to you Dr. Ed Benzel. It's a great honor for the esteemed position he holds today in academic neurosurgery. He's got a number of scholarly writings and his incomparable contributions to the advancement of spinal surgery education. But it's also my great pleasure to introduce him because I count him as a true friend, a colleague, and most importantly, he's my mentor. Dr. Benzel was born and raised on the eastern plains of Washington State. Originally, he graduated at Washington State University as a chemical engineer, but jumped over onto the medical field, graduating from the Medical College of Wisconsin in 1975. He completed his neurosurgery residency there, followed by a spine fellowship under the renowned spinal surgeon and investigator Dr. Sanford Larson. Then to our great fortune here in Shreveport, Dr. Benzil came over to LSU School of Medicine in Shreveport as an assistant professor, where he led the Division of Neurosurgery for the next 8 years, inspiring a number of medical students and at least one general surgery resident to pursue a residency in neurosurgery. In 1989, he went to the University of New Mexico, where there he established the first neurosurgical residency program in New Mexico. And here I, fresh out of my residency program, again was able to join Ed at a new founded department, where now, after mentoring me as a surgery resident, he now mentored me as a young faculty member. 10 years later, he was to Ohio as the director of spinal disorders at the Cleveland Clinic, later becoming the director of the residency program, and then on to the chairman of the Department of Neurosurgery in 2007. Currently is chairman emeritus and director of the career development of the Cleveland Clinic Neurological Institute. Between these academic titles, though, the bulk of his labor, one being a teacher, mentor, and inspiration to innumerable residents and spine fellows, which at last count were exceeding over 200 people that he has trained, as well as his voluminous contributions to the neurosurgical literature. There's over 300 manuscripts he's authored, over 400 book chapters, and 28 textbooks, including my go-to 2-volume text for spinal surgery called Spinal Surgery Techniques, Complications, Avoidance, and Management. So focused on spinal disorders, his major clinical research interests have embraced many aspects of neurosurgery, including Chiari malformations and syringomyelia, management of neonatal interventricular hemorrhage, cerebral vascular disease, neurocritical care, and traumatic brain injury. He's on the editorial review board of the Journal of Neurosurgery, Neurosurgery Spine, and the Spine Journal, and currently he is editor-in-chief for World Neurosurgery. With all this, he remains actively involved in the CNS, NNS, SNS, and is the director of the Cleveland Spine Review. He's truly lectured all over the world and has proctored an uncountable number of hands-on spine courses. It is again my great honor and great pleasure to introduce to you a marathoner, runner, triathlete extraordinaire, an avid motorcyclist, and the author of some historically notorious after-work parties here in Shreveport, Dr. Ed Benzel.
Can you hear me okay? Yeah. We'll leave it the way it is. Well, thank you, Brian. It is indeed an honor to be here, and perhaps what I'm most proud of is the last thing you said, the parties here in Shreveport. I got to tell you, I came here in November of 1981, and my family moved here 2 months later. I stayed in a dormitory in the hospital here, or in a residence call room in the hospital here, and I left Milwaukee, and I never looked back. A lot of the stuff that you mentioned that is non-spine that I worked on, like neonatal hemorrhage, interventricular hemorrhage, aneurysms, ECIC bypasses, whatever, that work came from my work here when I was still a general neurosurgeon. I subsequently began focusing specifically on the spine. I have extraordinarily fond memories of LSU. I came here, like I said, in '81, and I joined a partner who soon left. Dr. Lewis pointed out the fact that I was the only neurosurgeon for a couple of years, and it was an arduous task. Dr. Smith, through all of this, was a wonderful colleague and had supported me as much as humanly possible, and I am forever indebted to him as a long-term colleague and mentor as well. This morning, I'm going to talk about, first of all, I gave Dr. Willis a bunch of topics, all of them clinical except this one. And he said, this sounds good. And so I'm going to talk about leadership. And I'd like to start off by stating that everybody in this room is a leader. And I'm going to say that again and again here. And I also mentioned to Dr. Willis this morning that when you get to be my age, I've been in this business now for 40 years. And when you get to be my age or older, you can pretty much say what you want. You can't get away with a lot of stuff when you're younger. And so I'm going to take some liberties today and talk about what I think it takes to be a leader, to be successful as a neurosurgeon or in life. These are my disclosures, and I won't dwell on this, because they are not relevant to what I'm speaking of. I have 3 objectives here today, and I'd like to outline them: to recognize the importance of leadership, to discuss the principles associated with the development and maintenance of a rewarding career, and to appreciate the overarching importance of doing what's right and how such is fundamental to the establishment of the foundation of career satisfaction. So often in neurosurgery, we focus on this, the X's and O's, crafting that operation that's going to ultimately lead to success. But that's the hows. But sometimes we don't focus enough on the what's and why's. Who should we be operating on? And why are we operating, etc. So I'm going to talk quite a bit about that type of thing this morning. Ultimately, we all want to have a rewarding career. We need work-life balance. We need good partners and colleagues. We need to have fulfillment hours, case mix if you're a surgeon, institutional fit, work with leaders, and not so much bosses, and I'll talk about that in a second. And of course, taking great satisfaction out of doing what's right. So my first topic of the 3 is leadership, recognizing the importance of leadership principles and skills. Leaders are selfless. They do things for others, sometimes at their own expense. I don't know how many of you have read, or how many have read When Breath Becomes Air by Paul Kalanithi. He's a Stanford resident who died of cancer, and while he was on this journey, he wrote a book called When Breath Becomes Air. And it's an exceptional book. I had the opportunity to meet him but not get to know him, and met his wife and have worked with his wife subsequently. And I feel like through these experiences I now know him. But there was a portion of this book which I found particularly interesting. He and some other students were working on their mission statement, if you will, from the medical student perspective at Stanford University. So he writes, several students argued for the removal of the language, insisting that we place our patients' interests above our own. The rest of us didn't allow this discussion to continue for long. The words stayed. This kind of egotism, in other words, selflessness. Those who wanted to get rid of that wordage in the document is kind of an egotism, and it struck him as being antithetical to medicine, and it should be noted, entirely reasonable. Indeed, this is how 99% of people select their jobs: pay, work, environment, hours. But that's the point. Putting lifestyle first is how you find a job, not a calling. For most of us in neurosurgery, and probably most of us in the room, our work is in a way a calling, not just a job. We're passionate about it. We want to do a good job. We bend over backwards to do a good job and to help the people we work with. But leaders are also selfish, because we have to work that fine line between work and life. And we need to be protective of that, to be with our families, to be with those who are outside of our domain at work. Leaders are egalitarian, or relating to or believing in the principles that all people are equal and deserve equal rights and opportunities. This is fundamental to the foundation of a solid leader. So let's define leadership. This is my definition. the art of causing others to deliberately create a result that otherwise would not have happened. You can be a good leader or you can be a bad leader. Hitler was an exceptional leader. He caused people to do unimaginable things, things they otherwise would never have done. We need to reverse that in our activities of daily living and lead others, whether they're the patients, our colleagues, or whatever, to do something good that they otherwise might not have done. Leaders are socially aware, they have a vision, they have self-direction, they motivate, and they have self-awareness. Social awareness is, how am I coming across? Am I in the moment with you when I'm communicating? Am I empathic? Vision, we need goals. Self-direction, make decisions. Motivate the patient to take a pill, to lose weight, to stop smoking, cause them to do something they otherwise would not have done. And perhaps the most important of these is self-awareness. How am I coming across? Teddy Roosevelt made this statement, and I think it's beautifully stated. When people ask the difference between a leader and a boss, the leader leads and the boss drives. And this picture, a cartoon, basically tells it all. The leader is out front pulling in the same direction as everybody else, causing others to do something they otherwise would not have done. So if we become effective leaders, we have work-life balance, we have good partners, we have fulfillment, and it's all because we're doing what's right. Leaders lead. So let me introduce you to my partner, pediatric neurosurgeon, Violette Racinos. Here she is in an interaction with a patient, and obviously a photo shoot. But she is communicating with this little girl, and yes, she's having a good time, and the little girl is having a good time, but all throughout this, Violette is getting information, gathering information from a person who might not have otherwise provided it, because she led this young lady to do something she otherwise might not have done, that is, cooperate. There are many kinds of leaders if you look this up on the internet. Transactional leaders that work on reward and punishment systems, managerial leaders who do the same thing. But these are sterile, mechanical, unempathic strategies or fingerprints for leading. Maybe we need to look at operational leaders, someone who sees how individual elements of an organization fit together and then works to create the larger outcome. They think about issues, their focus is on what systems work. Transformational leaders do the same thing, and nowhere in here is the word punishment. Perhaps the best leaders are servant leaders. Leaders who basically work with employees and subordinates who then become an end in of themselves, and he or she works to support them and development of the bottom line. Some people become thought leaders, people who others look up to because of their wisdom or whatever. But all of these latter several are causing others to deliberately create a result that otherwise would not have happened. So many people want to be a leader for the title, but they don't necessarily want to do the work. Leadership comes from the heart. It comes from true leadership. It comes from the heart and is built around the concept of doing what's right. Leaders must work at it. It doesn't spontaneously happen. Now I'm going to show a picture of somebody that I'm not sure all of you know here, because I've become aware that professional basketball is not a big deal here in North Louisiana. But I'm from Cleveland, okay? And this guy is a really good basketball player, okay? After Cleveland Cavaliers won the national championship in 2016, the first thing he said was, "Cleveland, this is for you." And then he said, In Northeast Ohio, nothing is given, everything is earned. He probably works harder than anybody else in the NBA, and it shows. If you want to be a leader, you got to work at it. You don't always, the people who want the title, who want to get credit for things, ultimately will not be the best leader that they could be. And Harry Truman summed this up very well by stating, it's amazing what you can accomplish if you do not care who gets credit. So we can be a leader and say, see barriers, and there are barriers. The barriers are everywhere. But good leaders figure out how to break them down or break through these barriers. I would like, particularly the residents in the room at the various stages in medical, are there any medical students in here? Okay, great. So I'm going to start off with you as an example, and I'm going to talk about competence. Let's just say you're interested in neurosurgery, and you rotate on the service. You're incompetent because you don't know anything really about neurosurgery. You just know you're interested in it, but you really don't know what you don't know. So you're unconsciously incompetent. That's not a knock, that's just a fact. Then if you get into the program, and some of the junior residents here, the interns, etc., begin to understand what they don't know. And that's scary. They become consciously incompetent. They work at it, and over time, they develop competence. Say in the second, third, fourth year, they become consciously competent. They've got to stay on their toes day in and day out in order to perform at a high level. And then towards the chief years, they become unconsciously competent. They work by reflex. They take care of problems reflexively. They do this because of habits. We all know, though, that there are two kinds of habits: good habits and bad habits. And the problem with this phase of training, and it's a risky time in residency, is that they develop bad habits and don't know it. And ultimately, if this chief resident, as he or she goes out into practice, reflects on what they do, what he or she does, then they've developed the ultimate reflective competence. Leaders perpetually reflect. We need to be reflective of what we do in the clinical arenas, understand our mistakes, etc., understand the limitations of our knowledge, all of us, in all domains of life. How many of you understand or have heard the term heuristic? Heuristic is basically a rule of thumb. We should all have these in our back pocket. I'm going to give you two now that point out the dangers of how our minds work. Both of them, here they are. Before you conclude that a treatment was effective, look for other explanations. And the second rule of thumb that I'm going to discuss is, if you see evidence of success, look for evidence of failure. We so often just see only the good stuff. So before you conclude that a treatment was effective, look for other explanations. Now, this is a large extruded lumbar disc fragment, and we would take credit as a surgeon for the relief of the symptoms if we took it out. Well, this patient came back to see me for the pre-op evaluation, and her pain was gone. I could have operated on her maybe a month earlier and taken credit for resecting the lumbar disc, but in the fact that I waited and the pain subsided by itself caused me to think about the virtues of taking credit for everything I do. We subsequently got an MRI on this patient, and the disc was gone. The second one is, if you see evidence of success, look for evidence of failure. So often we look back at our successes on the ward, successes with surgery, and think, wow, that's a great case, and here's one of them. This patient had a laminectomy infusion by me, and her myelopathy improved substantially. So I'm pounding my chest and saying, this is great. The only problem is she's got a lot of neck pain. And I can ignore that because the myelopathy improved. That's what I was supposed to be taking care of, right? I was supposed to make her so she wasn't so clumsy, so her gait was better. And I did do that, but now she's got a neck pain problem. Why? Let's look at her pre-op flexion and extension views, and she can extend fairly well in the right picture, but I didn't get her back into normal extension with my fusion operation. Now I put her in a imbalanced situation. She's got for the surgeons in the room, she's got a positive sagittal vertical axis, and now she's straining constantly, reflexively, to put her neck back in position. So she was not a success. She was a failure. I asked this question: how many of you have ever gone to the workplace in the morning with the intent of pissing somebody off? You have? No. I think we can honestly say that none of us ever do that, and maybe there's an exception. I'm not sure, but for all intents and purposes, we don't. And you know why? Because we all care. We all want to have positive interactions. We all want to be liked by other people. But what happens to all of us sometimes, and some of us more often than not, at the one end is the disruptive provider who is at risk for losing a career. At the other end is the angels. Nobody really is an angel, though. What the people who cause other people to be pissed off do is not express the fact that they care. That is self-awareness and social awareness. You cannot learn to care, but you can learn to keep a high vigilance for expressing the fact that you care. That's empathy. So here are these characteristics of the leader. The top and the bottom one are really critical here with interpersonal communications. Leaders inspire. Dr. Willis mentioned Dr. Sanford Larson, who was actually a lousy teacher, but a great mentor and leader because he created an environment in which to learn. After all, what else can you do? That's what we do as surgeons. We create a better environment for the spinal cord or the brain by taking pressure off. He created an environment for his residents and students, nurses, and many others to learn. And this quote isn't his, but I attribute it to, I fashioned it after him. I cannot teach you anything. The most I can hope is that I can cause you to learn. Again, we're all leaders with our patients and their medications and exercise and diet, our colleagues and friends, build something together, solve problems together, respect each other, trust each other, loyalty, mutual respect. Let's go to the second objective, and that is discuss the principles associated with the development and maintenance of a rewarding career as a human being in academic or the community. Leaders are wise. Can learn to be wise too. Albert Einstein, who was goes without saying, was a genius, but he also was deeply, deeply concerned about mankind and about how his discoveries could be misused. He said, "The most important human endeavor is our striving for morality in our actions. Our inner balance and even our existence depends on it. The only morality in our actions can give beauty and dignity to life. To make this a living force and bring it to clear consciousness is perhaps the foremost task of education." This is his quote. I'd like to change one word here: the task of communication. Dealing with other people, one-on-one, one-to-many, etc. It's much more than the X's and O's. Sir William Osler, who was a dear friend of Harvey Cushing, William Osler being basically the grandfather of internal medicine and Cushing the grandfather of neurosurgery, or the father of neurosurgery. And I'll go so far as to extend it to endocrinology, because he described one of the first endocrinological syndromes, Cushing's disease, and anesthesia. He developed the anesthesia chart, checking blood pressures and documenting them during the case and observing trends that prove ultimately to be risky or fatal. But Osler, a contemporary, said in his treatise, The Student Life, "Begin early to make a threefold category: clear cases, doubtful cases, and mistakes, and then learn to play the game fair. No self-deception, no shrinking from the truth." And he goes on. Again, clear cases, doubtful cases, and mistakes. We must fess up, to say this in a word, to our mistakes. We must own them. So let me go back to this case. I must own up to this mistake, and I must strive and be reflective to try to not let this happen again. So to the neurosurgeons and to everybody here, here's Harvey Cushing, a remarkable man who basically did so much with so little in neurosurgery. Here he is documenting, and on the lower right picture is one of his books where he documented, drew, and placed photographs on every case he did. This portfolio helped him to remember, to be able to go back to, and to help him design care plans for other patients moving forward. So for the residents here, I recommend that when you graduate, you start day one keeping a record of every single case you do. Now, it's becoming easier to do with the new portfolio system. I use a system in the Stone Ages that I categorize cases by surgical and non-surgical, and by cervical and cervical thoracic, Chiari and syrinx, and all the way down. And then under those subcategories, I had further subcategories. And then I would put a file for each patient. I put a black line through here to de-identify, HIPAA rules. I de-identify the patients. But I'd have a descriptor for each patient, and inside these folders are photographs, images, pre-op, post-op images, etc., and the patient's story. And it can be a pain to record this, but it is proven for me to be an excellent source of data for research purposes, but also cataloging to help me take care of my patients more effectively. It's all about the what's and the whys, and some people get hung up on the doing of surgery. So now, about 10 or 15 years ago, I was at a North American Spine Society meeting, and I sitting there with a group of about 400 to 500 people, or surgeons in the audience, and we had an audience response system, and so there were talks and people asked questions and we'd answer questions, and one of the speakers presented a case of a patient with back pain, and he asked how many of the people in the audience would recommend surgery, And about 80% said we'd recommend surgery for this patient. Then he came back later and asked this question: how many of you would have surgery if you had this in your back? And 20% said yes. That's really damning to our profession. That violates a lot of ethical principles. And so there was a disconnect. There's not a lot of wisdom in that disconnect. So knowledge is the collection of dots. Experience allows us to connect the dots. But there's a little bit more than that. There's this patient centricity that becomes integral to the bottom line. Nietzsche, the guy who said that which does not kill us makes us stronger, also said the most common lie is that which one lies to himself. Lying to others is relatively an exception. So I'd like to try to make it so we don't lie to ourselves. And add, this is my definition, up to this point is the definition in the textbooks, if you will, on clinical wisdom. But I add this last part: the ability to effectively assimilate data, observations, and prior experiences for the purpose of optimizing clinical decision-making by using a patient-centric approach. Who can read this? We don't have any ancient Hebrew scholars in the room. This is ancient Hebrew. It's Leviticus 19:18, about 2000 BC. It is the first Western recording that I know of the Golden Rule. Do unto others as you would have done unto you. I'd like to look at wisdom and intelligence and put them together a bit. They're sort of like overlapping rings. This guy, Mr. Wolf, is very wise. He's not very smart, though. He can't do long division or differential equations. But he's cunning. He lives in a very hostile environment and is successful. So I'm going to put him over here in the wisdom part, way away from the intelligence part. Those people who would do a lot of surgery, those surgeons who would do a lot of surgery that they wouldn't have done on themselves, I'm going to put them over onto the right. They may be very intelligent. Because they may have high volume, they may be very good surgeons. But are they doing the right thing? We have to be very careful of this, and we don't want to be that guy or gal who's doing the wrong thing. So really, we want to kind of be walking in a tightrope and sitting in the middle. We also must interpret the literature, and I've already alluded to this a bit, but Mark Twain, who probably got this from Benjamin Disraeli, who probably got it from another source, because there's almost never an original thought. There are three kinds of lies: lies, damn lies, and statistics. And a guy named David Casseret in 2013 in the New England Journal wrote a great article on the illusion of control. And he talked about, in this article, he talked about the therapeutic illusion, and that the outcome of virtually all medical decisions is at least partly outside the physician's control, and random chance can encourage physicians to embrace mistaken beliefs about causality. I could take my patient with the cervical fusion and decompression and say it was successful, and put my blinders on, and in my own mind, I was strong, I was good, I did the right thing. That's a therapeutic illusion. This leads to confirmation bias. Once treatment is underway, physicians and patients tend to look for evidence that it is having some kind of positive effect. Conversely, not looking for evidence that might be causing a negative effect. So there's a lot of research that's published out there, particularly in the spine arena, with IDE studies and industry-funded studies that are very biased, and they're conclusion-based. The authors set out to prove a point, and you can always design a study that will prove whatever you want to prove, versus process-based research, exploratory inquiry. I think we're going to be seeing much more of this as we learn more about it moving forward. Again, therapeutic illusions lead to confirmation bias. So, teams. We need teams. We cannot work in isolation. We need support. We need an enriched environment. These are a lot of the people with whom I work in days gone by and today. They, for the most part, are hardwired. We think alike. When we make eye contact, whatever one of us says to the other, it's going to happen. We can get it off our plate. Saves a lot of time, saves a lot of spot checking, etc. This is my spousal unit, my wife, Mary. My advice to folks is, if you don't have one, probably should try to get one. If you have one and he or she is good, work really hard at keeping your spousal unit. So now we move on to the third and final objective, and that is appreciate the overarching importance of doing what's right and how such is fundamental to the establishment and foundation for career satisfaction. I am going to actually get a little clinical here, Brian, okay? But not necessarily surgical, but cautionary regarding surgery. Again, leaders do what's right. How many of you recognize this guy? If you were alive in the 60s and watching TV, this is Marcus Welby. He's had a TV show, Marcus Welby, MD. That was his name. His name was Robert, what's that? I don't think so. Robert somebody. But he played a primary care physician who was all things to all people. You know, kind of the next generation of those who took chickens and eggs and goats for caring for patients. Patients paid for what they could, and if they couldn't, he took care of them anyway. That was value-based medicine in the old days. That pyramid has been flipped as we emerged into the 70s and 80s and 90s. The lady in the upper left is Diane Carroll, by the way. She played a role, Julia. She was the first African-American sitcom star, and she played a Angel of Mercy nurse in the same era as Marcus Welby, MD. But they were in the era of value-based care, and then we switched to volume-based care, where we're in the 90s and 2000s, and now trying to get back to value-based care across this chasm that's deep and long. We're trying to work from volume to value, from market pressures of doing a lot of work because we get paid by the piece, to doing what's right. And the problem we have in medicine today is typified, I think, by these two canoes. We have our foot in one canoe, which is the volume-based care canoe, and are tiptoeing into the value-based care canoe. And so far, things are rough but okay. But when these canoes start to diverge and go apart, we need to jump into one canoe or the other, or fall into the chasm. The good we do is the value-based care canoe. What and how much we do is the volume-based care canoe. In the good old days, doctors often didn't know or ask how much they were paid for individual services. Rather, their concern was simply that in the aggregate, they made a reasonable living. Insurers never influenced the patterns or types of care and simply served as financiers and redistributors of the funds dedicated for healthcare provision. Industry was not involved with the provision of services such as reimbursement support because it did not affect the usage of their product. Hospitals would tolerate losing money on one service because they gained it on another. We're kind of talking about the era in which I was here in LSU. But doctors, insurers, and industry then began to increasingly focus on reimbursement, the almighty dollar, and the emergence of volume-based care came on the scene with practice managers, reimbursement specialists, device and pharmaceutical manufacturers, manufacturer advocates, consultants, specialty hospitals, political action committees, administrators. They always say, know your audience. Is there an administrator in the room here? Good. Okay. Let's look at the growth of physicians in the last 50 years, the green curve on the bottom, and the growth of administrators. If we want to know where the cost of care is going, in large part, it is going into non-productive component of the medical community. Our system was not built to tolerate this onslaught of financial interests and from multiple sources. So what is more or less happened in that time frame is that the cost of healthcare has increased from, in the 70s, 7% of the gross domestic product to nearly 20% of the gross domestic product today. That's the crisis we face. Some of that has been related to this, but some of it, or a lot of it, is related to our own undoing. This is how much it costs in the United States for health care per capita, roughly $7,000 per person per year. And if you multiply that times 300 million people, that's roughly $2 trillion for health care in the United States each year. That is $2,000 more than the next greatest expenditure country, which is Norway. $2,000. Well, our infant mortality is higher than many other first world countries. Our life expectancy is lower than many other first world countries. If we look at the quality of life index, we in the United States are at 31, lower left, while if we look at the power index, we're number 1. So are we getting our money's worth? Evidently not. Frank Smith is a renowned Canadian orthopedic surgeon. He said, "It has always been a source of bewilderment that the richest and most powerful nation in the world should have a healthcare system that, while providing state-of-the-art services to those who can afford it, and thus the most likely to not need it, either leaves the less fortunate denied or rendered destitute by the cost of care." So here we are. And if you're a healthcare decision maker, what kind of a choice are you going to make? Atul Gawande, who's a medical writer and a surgeon in himself from Boston, basically in this article on overkill talks about the fact that physicians overtreat. When you overtreat, you spend more money. One operation leads to another operation. One medication leads to a complication and further medications, and so on and so forth. And if you look at this map, probably most of you have seen some rendition of this. This map shows the difference in per capita rate of spine surgery in different regions of the country. And in some of the regions of the country, the incidence of spine surgery per capita is tenfold greater than in other regions of the country. In 2003, I had moved from New Mexico. I went to New Mexico. I left Louisiana in '89. I left New Mexico in '99, so I was in New Mexico exactly 10 years. And I came to the Cleveland Clinic, which has a much better infrastructure for marketing and media and all that kind of stuff. And so when I got called by the New York Times in 2003 for an interview about back pain, I immediately went to our marketing people and the media people and said, okay, what do? I don't want to stick my foot in hot water here. And they said, oh, this is simple. It's a telephone interview, so you don't have to look pretty, which is very good. They said, what we want you to do is to have 3 sound bites. And so I got, and the next statement was my introduction to becoming a politician. They said, no matter what they ask you, you answer with one of these 3 sound bites. If you only come back to those 3, you will not be misquoted. And my 3 sound bites were that surgeons cave into market pressures. I've already alluded to that. That less than 50% of the operations for pain, fusions, were probably appropriate, and that the system for physician reimbursement is perverted. I think all of those are true. I didn't make a lot of friends with the second statement and the first statement. In fact, I jokingly state that I had somebody start my car every evening for me before coming home. That I'm not serious. So I would like to talk about what it is we in the medical community can do that may make a difference. And it has nothing to do with politicians. Let me just say this, that 10 years later, this was 2003 when I made this statement, 10 years later, in 2013, the per capita rate of spine surgery for pain increased 3-fold. So if we were doing twice as much surgery, if that's correct, as we should have been in 2003, we were doing 6 times as much as we should be doing in 2013. So chronic pain is the elephant in the room. There are many chronic pain syndromes, not just spine related. The TMJ, headache, pelvic pain, GI pain. GI pain may be the most prevalent. Joint pains, fibromyalgia, back pain. We spend about $635 billion on chronic pain annually. If we could cut that in half, cut it in half, because money we spend on chronic pain is in general money poured down a rat hole, because it's like surgery in patients who don't need it, etc. We could, if we could diminish it by 15%, we could decrease our gross, the percentage of healthcare expenditure compared to the gross domestic product by a considerable amount and take us back to the way we were in the mid-90s. Can we do that? I don't know. We must look at value, which is quality over cost, and when utilization does not correlate with value, we have a disconnect that we should fix. If we don't do something, the lawmakers will. Now, we have very poor data that shows that lumbar fusion is an effective operation. If I was a lawmaker and I knew nothing about medicine and saw those statistics, I would say, we're cutting that out right now. And we do know for sure that there are some patients who benefit from lumbar fusions, but we're not picky enough yet. I'd like to discuss back pain and just get a little bit into the nuts and bolts of back pain, because we say back pain and we like it's one entity, and it's not. There's myofascial pain. This is usually the episodic pain where the patient's got a tender back and muscle spasms. There's inflammatory back pain, like that associated with ankylosing spondylitis, usually seen in young adults. There's mechanical back pain, which is, could be due to some instability, which we might be able to help with some sort of a procedure that stabilizes the spine. And then there's chronic back pain, which means it's been around for a long time. And if it's a syndrome, it means that it's associated with all sorts of psychosocial behaviors, etc. We know some of these patients, but we don't know all of those patients, the crazies that come into our clinic. Myofascial back pain hits all ages. It's episodic, muscle tenderness, and it's the most common. Inflammatory is young adults. patient with ankylosing spondylitis, most commonly a male, will present in the 20s with back pain, gradual onset. This pain is a early onset in the day and then gradually dissipates as the patient gets around throughout the day. A unique symptom complex. They might have an image that shows sclerosis of the SI joint. They may have a positive blood test. Mechanical back pain, that pain that we might be able to help, is deep and agonizing pain that is worsened by loading, worsened by standing, lifting, walking, and improved with unloading, laying in bed. Critical. If the patient cannot make the pain go away in a position, it is probably not mechanical back pain, and if we're going to do an operation for that, it's probably not going to be ultimately successful. I'm going to talk about this in a second, but we looked at our cases at the Cleveland Clinic, and 1/2 of the cases did not have, that had a lumbar fusion, that had a decompression, not even a fusion, a decompression for sciatica, a discectomy, or a laminectomy for stenosis. 1/2 of them did not have relief of their symptoms or had a worsened outcome after the surgery. The syndrome is associated with non-restorative sleep, low energy level, decreased activity. These lower psychosocial variables are often associated with depression. Most of these patients are depressed. I'm going to introduce a term called pseudo-concordance, and I'm going to define it as such: an apparent but erroneous relationship between an assumed cause, i.e. imaging study, and an effect, back pain. So, does the imaging study correlate with the back pain? And I'm going to state up front that the imaging study tells us about anatomy and pathological anatomy. It doesn't tell us a diagnosis. The diagnosis is a clinical observation based on clinical findings. I would like to make that perfectly clear here. So let's take the case of a young man in his mid-20s who has these symptoms. Early morning pain that gets better with time. We don't know that his x-ray shows this because we didn't get an x-ray, but we did get an MRI because we always get MRIs on people with back pain, right? That's another, for starters, that's a waste of money. Having said that, he's got an L4-5 spondylolisthesis and stenosis. So he really has a inflammatory back pain syndrome, but has an imaging finding that suggests that he's got a stenosis. The clinical diagnosis should be ankylosing spondylitis or inflammatory back pain, but instead the surgeon takes the view that the imaging finding is consistent with a clinical syndrome of back pain, and he operates on the patient. Does a decompression and a fusion and puts in screws and rods. And now the patient is pegged as a failed back because he didn't get better. And in fact, his pain is worse. And so the next surgeon on the line says, well, this operation didn't work because we didn't do enough, or we needed to do another operation. And 3 or 4 operations later, the patient is a cripple, and they still haven't made the diagnosis of ankylosing spondylitis. And he hasn't enjoyed the benefits of perhaps the biological therapies that so appropriately and effectively treat these patients today. So this is pseudo-concordance. The doc did not see the elephant in the room, the inflammatory back pain in this case. So let's look at a chronic back pain syndrome patient. He presents with non-restorative sleep, low energy level, decreased activity, he's on opiates, and he has that same imaging study. So the doctor operates on this patient because he's got lumbar stenosis and an L4-5 spondylolisthesis. The problem is, that's the imaging finding, and his syndrome, his clinical finding is chronic pain syndrome. Again, 3 or 4 or 5 operations later, the patient is a psychosocial, psychological, and physical cripple. And the surgeons have made some money. Anybody know who this guy is? He actually played for the Cleveland Indians. He was one of the first African Americans to break the color barrier. Not the first, but one of the first, but perhaps one of the most athletic people to ever have played baseball. He didn't get into the major leagues until he was in what people think are his mid-40s. He didn't really know when he was born. His name is Satchel Paige. And my father and mother, before I was born, as Dr. Willis said, I was born in Eastern Washington. They used to go to Spokane, Washington, and this guy, Satchel Paige, would put on a show after he had retired from baseball. And my father once told me the story that he would stand on the pitcher's mound. He had huge hands with four balls in his hand, and he would throw a ball to the catcher, first base, second base, and third base with one swing. So he was a remarkable athlete, but he was also a character, kind of like Yogi Berra, if anybody remembers him, had sayings for things, and this is one of his sayings that, by the way, he stole from Mark Twain. He says, "It's not what you don't know that hurts you. It's what you know that just ain't so." So we know this patient has spondylolisthesis and back pain related to this, but we didn't look hard enough. We didn't see the elephant in the room. It just ain't so. So when assessing patients for surgery, proceed with caution and think. Look around. Is there an elephant in the room? Think clinical diagnosis. Think clinical diagnosis. Then ask, does the imaging correlate? Don't look at the imaging and ask if the clinical correlates. Develop an opinion on what you think the patient has based on the clinical findings and history. And I put this down here on metrics. We use a lot of these metrics, patient-reported health-related quality of life data, the PDQ, pain disability score, various PROMIS modules, PHQ-9, which is a depression score. These can be very revealing and help you sort out this patient population. Remember, asking these questions is very simple. Do you have restorative sleep? Are you fatigued? Are you on chronic opiates? If the answer to those 2 or 3 of those questions is yes, you're probably dealing with a chronic pain syndrome, and they more than likely will not get better with an operation. And then I put down at the bottom AI, artificial intelligence. I think we already have enough of that, but the new kind of artificial intelligence allows us to look at massive amounts of information, and we're developing a program at the Cleveland Clinic to put together multiple variables and predict from that whether a patient is to have a good outcome or a bad outcome with surgery. At UCLA, they're working on an imaging correlate of that. The system can look at the patient's images and tell us quite a bit about the process of predictability of improvement. We can treat these patients not with surgery, but we must have other treatment strategies. The patients want passive strategies. Those are pills, surgery. Lay on a table and the patient says, "Doctor, heal me," because I don't have to do anything myself. They're averse to weight loss, cessation of smoking, exercises. We've got to empower them to fix themselves. Core strengthening, flexibility, smoking, weight loss. Empower the patient. There's a thing called, any psychologists in the room? Physical therapists. There's a thing called cognitive behavioral therapy, and working with these folks and trying to work on the psychosocial aspects of the behavioral aspects of their pain. And we have a study that's looked at 117 patients so far, in which we combined that with cognitive behavioral therapy oriented physical therapy, and have demonstrated a significant profound improvement in the patients who participate in the study. They work with the patient on hurt versus harm. Their pain hurts them, but it's not going to harm them. We treat with membrane stabilizers and wean from opiates. Opiates cause opiate-induced hyperalgesia. They make the pain worse. For a chronic non-terminal pain syndrome, in my opinion, there is absolutely no role for narcotics and for opiates. First, do no harm, primum non nocere. That's part of our oath. So identify the patient, look for the elephant in the room, make a clinical diagnosis. So in summary, in order to be successful, appreciate the overall importance of doing what's right in life and how such is fundamental to the establishment of a foundation for career satisfaction. Look at your work as a passion, not a business. Look at value, the good we do versus how much we do. Get our blindfolds off. Let us identify these patients who are not to benefit from narcotics, from surgical procedures, or other procedures, injections, etc. The elephants are everywhere. It is estimated that 1 out of 3 adult Americans has a chronic pain syndrome. That's why we spend $635 billion on chronic pain every year. We should all be both selfless and merge that or morph that into an element of selfishness for ourselves, for our families. And the more of us that are empathic and look at our workplace as a place to practice our calling versus a job, if we can do that, we will all be better. So each and every person in this room needs to lead, and that is causing others to do something they otherwise would not have done. I hope I have met these objectives, and I think if we follow these rules, we have a much better chance when we go home at night of feeling like, I did good today. I want to feel good about myself, and if I feel good about myself, the people with whom I work, the people with whom I treat, will also feel good about themselves. So I've used a lot of examples of people, and they have, all of these people in one way or another have inspired me. I'd like to close with a statement that we're in tough times right now in medicine, financial crunches and stresses, and it's easy for morale to go to pot, and we got to lead. Each of us got to lead each other through this environment. But Machiavelli portrays our time right now perhaps better than anybody. There is nothing more difficult to plan, more doubtful of success, nor more dangerous to manage than a creation of the new order of things. I thank you very much.
Limited time. Does anybody have any questions or comments that they would like to address to Dr. Benzil?
Welcome back, Ed.
Larry Embry, I was looking at that guy, trying to recall who he is. Okay, boy, great seeing you.
It's hard to find an area of improvement there, and thank you for selecting that title with multiple points in it. I would suggest that a wide audience would benefit from this. And if I had a magic wand, I'd put you in front of the Capitol building with a podium that you broadcast out of Washington. I think your ideas need to be broadcast to a much broader audience. Also, when I see an outstanding student extremely met with students, are outstanding individual. Anyway, this impulse comes in the back of my mind. I sure would like to meet your parents. And I've had that impulse about you. And I would say, God bless your parents for producing a person like you.
Thank you. I have a story. I was just at a major neurosurgery meeting, and your name came up, of all people. I was talking to a guy named Robert Rosenwasser, who was a student here, and you try to grab him and get him into neurology, and he resisted. He may have worked with do you remember him? Yeah, Don Smith, okay. And he went into neurosurgery. We just had, and he's now the chairman, he's been the chairman for some time at Jefferson, Thomas Jefferson in Philadelphia. But he spoke very, very highly of you, and it's just so coincidental that your name came up out of nowhere, and here we are talking today. Thank you. Yeah, yeah. Yes.
I think it's not just Gordon, and this is our team, and we run the surgical movement disorder clinic in town. And I think the opposite also is an example in your talk. You're talking about be careful to not do too much surgery that pays very well. And what our clinic does is we offer a lot of surgery that does pay well. And I think the opposite is true with what you're saying as well. I think a lot of people thinking about going into functional neurosurgery are very much turned off by the fact that the deep brain stimulation, pallidotomy, thalamotomy pay very poorly relative to a lot of other procedures. And I think that as a resident or as a student, if you're passionate about that, please don't let the fact that it doesn't pay well skew you away from that, because there are ways to work within the system, and it's hard, as you mentioned, but there are definitely ways that we have worked in this community to be able to all make a reasonable living and still be able to offer a tremendous amount of this procedure to a four-state area. And so I would just encourage that the opposite is also true. Don't chase after surgery that make a lot of money that aren't necessary, but also don't shy away from something you're passionate about because it doesn't promise a lot of money.
I couldn't agree with you more. Like, one of my 3 sound bites when I talked to the people at the New York Times was that our reimbursement system is totally perverted. Y'all, pediatric neurosurgery, the clinical psychologists and the people that deliver this care, we need to shift the reimbursement to those who do the best, the good. We need to reimburse people for the good they do, not how much they do. And I'm a spine surgeon. I fell into this. We're paid better than practically anybody per unit of work, anybody in medicine, and it isn't fair. And I understand that. It just isn't. We somehow have to get this. Create a level playing field.
What if you have a patient, you allow the lordosis, but they still have neck pain? What do you think about in a situation like that?
Well, and I think the chance of the patient having chronic neck pain, if they didn't have it before, okay, when you restore normal alignment, and it's not just lordosis, it's also, for the spine surgeons in the room, the sagittal vertical axis. In other words, you want to have the spine in balance. You want C2 over C7 over S1, okay? And if the patient's in lordosis, their spine is bent backwards, but it's leaning forward, say from an upper thoracic, kyphotic posture, that patient's going to be very unhappy. You want to get everything lined up. Bottom line is, I'm gravitating more towards, motion preservation surgery, like laminoplasty, for example, which I think has at least in my eyes, an increasing role in the management of spondylotic myelopathy.
The reason I ask is, it seems to me, a lot of what we do, there's no
Well, knowledge plus experience plus patient centricity. If we don't have data, well, first of all, if we do have data, be very cautious, because the data probably is flawed. I'm going to make a statement which could make somebody angry in the room, and I don't care. And that is, I believe that all the data on artificial discs, cervical and lumbar, is completely flawed and needs to be thrown in a dumpster. And started on fire, okay? Having said that, I've said that at a meeting and somebody comes in, then how are we supposed to make decisions? And that's the same question you're asking. And I say you need to think through what's right, but not have the blinders on saying, I know it works because I read a study that said it worked. The study was done by surgeons, all of whom support artificial discs. It has been funded more than likely by industry, who makes money from the artificial discs. And there's study designs that cause bias. There's a winner-loser bias in those studies, where the patient, if they don't get the artificial disc, wants to, feels like they lost the lottery. And then there's the methodology. The patient's decision to go back to surgery, which is the endpoint of a lot of these studies, is made by a biased surgeon. And so we have to be very careful. And so if you do artificial disc surgery, or you want to do a fusion, or you want to do a laminectomy, and there is no data, and let's just say there is no data, then you have to sit and reason with the patient, in my opinion, and together make a decision about the best thing to do. And up front needs to be the option of doing nothing or doing physical therapy. And if the patient has even an inkling of a chronic pain syndrome or is on narcotics, I will not do elective surgery on a patient on chronic narcotics. Will not touch them. Yes?
Okay, so on the topic of patients being seduced by sexing technology and experience study, what's your opinion about laser spine surgery?
One of our residents called, we have a laser spine, are you talking about the Laser Spine Institute? Ask Hulk Hogan. Yeah. But at any rate, we had a resident that called up the Laser Spine Institute a couple of years ago in Cleveland and asked, he says, I got a lumbar disc, how much will it cost? And he says, well, depends on how many discs there are. It'll be $25,000 per disc. You come in, have an evaluation, and we'll put you up in a hotel that night after surgery, free. And then you go home. Then you go home the next day, cash on the barrelhead, and no inpatient costs, all outpatient. So what do I think about it? I've had several patients. I looked at the op report, I looked at the incision, or lack of incision, and asked, what did they do? I have no idea what they're doing. It's a scam. It's a complete scam. How many of you in the room have had laser spine surgery?
A follow-up question, if I may. How should our society of neurosurgeons and spine surgeons address that issue, protect the public from these scams?
So, years and years ago, I gave some money to a political action committee for the AANS. And that money was used to support a candidate that I would have never supported. And from then on, when they come and talk to me about donating to a political action committee, I look at them in the eye and say, I can't trust you. I'm going to choose my battles myself and to go my own way. Having said that, what political action committees and a lot of organized neurosurgery do is to look out for us, the surgeons. Now, how do they look out for us? they look out to get us more money. They look out after our financial well-being. That's antithetical to what I've been talking about here today. So we got to quit doing things that are in an attempt to pad our pocketbooks. We need to do things like work with artificial intelligence and these health-related quality of life metrics and look for ways to sort out who shouldn't have surgery. If we can be known for that, we got to make a positive move in the face of legislators, in the face of the public, because we're becoming increasingly scrutinized for doing the wrong thing. We got to start doing the right thing, and it's going to take a long time. But major changes, there's been a couple of major changes, one major change, at least in Ohio, and I don't know about Louisiana, that we can no longer prescribe narcotics for chronic pain. Now, that to me is a great deal. It's long time in coming, but it's there now. And now patients are forced to do other modalities and other treatment strategies, maybe cognitive behavioral therapy or whatever. And the other is this chance that we're going to be able to mine data so that we can determine who should have surgery. In fact, insurers won't pay for surgery if a patient falls below a line as far as chance for a good outcome. I think those are good things because we can, in a sense, it takes our decision-making process out of it. But on the other side of the coin, it causes us to, for the most part, do what's right and forces us to channel patients into better modalities of care.
I don't know if you remember me. Welcome home. This is Swing Gate Line.
Okay.
It's been a while.
Yes.
At any rate, I think the most powerful thing you said was when you told the audience and 80% would operate, but only 20% would have the operation. If you're trying to be truly patient-centric, you need to keep that in mind. If this was my mom, would I do this? If this was me, would I do this? And I think if we consider things that way, we'll make better decisions. And I think that was the most powerful thing you said.
I think you're absolutely right. One of the things that I often tell people, and this isn't my original line, but it is, the more I do, the less I do. And I come under the gun from our institution because my clinical volume, surgical volume is down, or lower than most, because I don't operate on a lot of people. But there will come a day when those surgeons will be reimbursed more than those who do too much. And I don't know when, but we're getting there. Thank you very much.